a general dentist should listen to my lecture. The majority of the lecture that you go around will prepare you to face Giselle. Giselle is a beautiful lady that does not need any real intervention, but just to improve her beautiful, already beautiful smile. And so you will do maybe on Giselle 20 veneers aesthetically. She will have all the teeth, all the money, and beautiful final picture. This is what we see on the social, on the article. And after, a general dentist go back and find and face reality. So what is this patient? This patient is what happened to our population when we don't do a global vision, but we do single tooth dentistry. A little repair there, a little repair on the other side, and one day everything starts to fall apart. So a dentist will find a patient that does not have money, does not have time to be seated in the dental chair, and does not want to be with us because the patient is used to our type of dentistry. And so I wonder if we can do something different. Because when I speak to many of you and I do treatment planning of your own cases, the one that you are doing in private practice, and these are even just some of them, and they are not the hardest one. And so when I discuss with you, I realize that there is really never a diagnosis. If the diagnosis is not there, how can you collect the correct information to do what? A project with the laboratory technician. And this project should be test drive before irreversible change happen in the patient mouth. And so this is part of the treatment plan. So if you think about it, sometimes we tend to immediately work on patient. So when you see this mouth, this patient has invested so much time to have a mouth that I'm sure was not working already in the WhatsApp. So that's why the beauty of the three step is not that people should do full mouth, but people should be aware of the patient that is facing. And this is called a diagnosis. After that, it should be a dance between the lab technician and the clinician to decide a project that should not go in the mouth if it's not correct. And when it goes in the mouth, should have the possibility to make mistake and to go back. So that's why I love this name. It's called additive prosthodontic because it's a reversible treatment. So what I do, because people say, hey, how could you have all these patients that accept your treatment plan? Actually, my patient don't have money and don't have time. But my goal is, my plan is to augment this population of patients. How? Well, for instance, I offer a different product. I stop with subtractive dentistry. It's not at all what the patient wants about it. Patient want to come to my chair, sit, sleep, and get teeth. Is it possible? Well, if you think about it, the first dentist that make crown, he is an intelligent one. But it's the second dentist that has to redo this mouth that has problem. Because imagine if these roots fell off, the patient loses a bridge. If this bridge is not there anymore, the patient will start to overload the other side, and now this part will break. And the patient does not have anymore a posterior support, and now it starts to chew on top of this part of the mouth. And so that means that even the front teeth that for the patient are the most important one start to fall apart. And so to solve this situation, we are supposed to have expensive retreatment, endo, extraction, implant, complex procedure that maybe a general dentist does not want to do. And after that, there are no guarantee because the first dentist, when he did the first crown, he provided long-term longevity because it was an intact tooth with all the vitality. But the second dentist will be in trouble because what the general dentist should have in mind is that we will see 30 years follow-up, or at least of our patient, and they will age. And age is cruel, and nobody tell us in dental school. So this woman, when she was 60, somebody told her that for the rest of her life, she should have had no removable. That now she still does not have a removable, she has a removable. And the dentist that will take care of her with no money, with no health, will face another problem that we now start to be aware of. Even the implants are failing. So when I look at the population that we dentists are creating, obstructive dentistry, I see these big groups. The over-treatment, the Giselle type, they are receiving what I call anti-aging of the incisal edge with no diagnosis. They are just bonding these beautiful veneers, not integrated in the function of the patient. And the incisal edge start to fracture the bonding, and we go with a harder material and we prep the tooth more. And so an intact tooth that was restored for aesthetic become already almost a crown. This is the first group of patients, and the second will be because we have placed too many implants in the patient without looking at even what type of patient we had. Because when I look at my patient, they have so many medication nowadays, and they cannot really not only afford implant, but also the bone is not good. We didn't have the biphosphonate in the 80s. This is the problem that we are facing now. So I decided, because I was supposed to be a prosthodontics, to change my way of thinking. I don't want this type of world. My word should be peace and love. And I invented a different way of doing dentistry. So this lady, she was 26 when she came and see me, and she wanted just a 6 incisal edge. I say, no, you need a global vision, a prosthodontic vision. But if I had say to her, she was not aware of the damage of her posterior teeth, you have to remove this, devitalize that, add crowns everywhere, she would have left me and go to the next door dentist. They would have give her the 6 teeth. The 3-step is additive. When she came to me, I obtained the space, not cutting her teeth, but add. So this is what I do, just to give you an example. This woman, these 2 premolar are vital, and any dentist would have devitalized these teeth. The patient came with no anesthesia, because I worked with no anesthesia, because I seal the dentin, and many of these sclerotic dentin don't even have sensitivity. I want to work without anesthesia because I want to test the occlusion of the patient, the function. And so this woman, in 2 hours, leave my office with this, that in the 3-step code is called the white bite. This phase was not obtained by subtractive dentistry, was obtained by additive. So to do this type of patient, you need to be excellent in adhesion, because you cannot take somebody like this and bond fast and furious. You need to bond in a quality way, but after that, you need to correctly protect adhesion with function. And this is what is missing. So the three-step was born for a biological reason, to avoid cutting teeth, and nowadays is more and more going back to function, but not the creative function, the function that help us to understand how to protect this beautiful additive restoration that this patient receive without anesthesia. Tell me if this patient does not go around her entourage to speak highly about her dentist, because everybody else would have proposed this to her, devitalizing crown, and she would have been in pain, because nobody likes that there is a dentist cutting in their mouth. I propose the A3 that are palatal veneer, double veneer, step veneer, tacos. This is the whole collection. So that gives new option to a dentist that wants to be trained, because it's not like this, let's go and do a single only. This is a full package. I think we have a huge population. I think when I look around, everybody would need a three-step. So now you can decide, is he a patient that does not have almost the teeth? This should have been taken 10 years before, not so degraded. But what you see here is the 12-year follow-up. But this is more difficult because you have to be good in addition, in bonding. But I say, what do you do if you have, for instance, a palatal damage? Would you go there and cut his teeth? You have to devitalize. By the time you remove the caries, you remove, the pulp is gone. What I did, I just seal the dentin, remove up at 11 years with the composite palatal veneer in this patient where I saved the whole unsupported enamel. And I know that the Eastern Europe is good in composite, because for years there was a privilege to receive crowns, was for rich. But nowadays, rich people should have this type of intervention, because 11 years follow-up, this patient didn't even want to do a bleaching. The teeth were not devitalized. This is the radiograph at 11 years. And this was the moment where I am just trying in the palatal veneer. So you can see that all the unsupported enamel was kept. This is one population. But the other population that absolutely should be used by dentists is when you have a plastic prosthodontist and you're supposed to redo everything. And I say, no, I do with additive, because I never remove this. Because I want a good foundation for my white bite. So this is the composite bonded on the existing crowns. So the patient, when you receive this treatment, no anesthesia, and I don't have to waste time in the removing the bridge, reline the provisional start to fall. No, the provisional will be correct. The same day, I can even check real function. So from here to there is 2-hour work. If I had been the way I was being trained as a subtractive prosthodontic, I would have cut all this crown. Why? It's too early. Let's stabilize the patient with the three-step. Later on, we go back and we remove by quadrant, but the rest of the mouth is still in the test drive. And the dentist can say, yes, let's go for more invasive, irreversible procedure.